People talk about intermittent fasting like there is a hidden lever. Skip breakfast, flip a metabolic switch, and fat loss becomes easier. But when a plan works, how do we know what did the work? Is it fasting biology itself, the shorter eating day, fewer snacks, or simply a calorie deficit that feels less like counting?
First, intermittent fasting is not one diet. Time-restricted eating compresses daily intake, often to a 6 to 10 hour window. The 5:2 pattern restrict calories on 2 days each week. Alternate day approaches rotate fasting or very low-calorie days with normal days. They all change timing, but they also change food opportunity, social friction, and the size of the weekly deficit. Physiologically, fasting lowers incoming glucose. Insulin secretion tends to fall, liver glycogen is gradually used, and fatty acids contribute more to energy. If the fast is long enough, ketones can rise. That is real biology, not imaginary. The mistake is turning a fuel shift during one part of the day into a guarantee of extra net fat loss across weeks. A helpful randomized trial compared an 8-hour eating window with a deliberate 15% energy-restricted diet in an unrestricted group. The time-restricted group was allowed to eat ad libitum, yet by the end they ate about one fewer meal per day and reported roughly 469 fewer calories daily. In practice, the clock behaved a lot like calorie restriction.
So when someone says, I eat whatever I want inside the window, the study suggests they may not actually eat the same amount. Is the skipped breakfast, the missing evening snack, or the reduced number of decisions doing most of the work? And does that mean the benefit depends on what the window removes?
Exactly, and the window did not automatically improve every nutrient. In that trial, saturated fat intake fell, which sounds favorable, but potassium and grain intake also fell. So the practical version is not just eat less often. It is protect protein, fiber-rich plants, and micronutrient-dense foods inside the smaller window, because compression can crowd out useful foods too.
Before we get too practical, who should not treat fasting as a casual experiment? I worry about people copying a schedule from a video while taking diabetes medicine, being pregnant, being a teenager, being frail, or recovering from disordered eating. Where is the line between a routine and a medical decision?
That is the right caution. For adults at risk of type 2 diabetes, one larger trial compared a 9-hour time-restricted window, ending by 7 p.m., with individualized dietetic guidance. At 4 months, the fasting approach was non-inferior for HbA1c, but not superior. By 12 months, non-inferiority could no longer be concluded, and the absolute HbA1c changes were small. That wording matters because non-inferior does not mean better. It means the clock-based plan performed close enough to dietetic guidance within a defined margin at that time point. The trial also reported minor adverse events and no difference between groups, which is reassuring. But it is still not proof of a durable metabolic advantage or lifetime safety.
What about continuous glucose monitors? People love screenshots showing a flatter night after earlier dinners. Is there evidence that closing the kitchen earlier improves overnight glucose? Or are we mostly watching personal data theater with too much meaning attached to a few smooth-looking lines?
There's a plausible short-term signal, especially when eating ends earlier. In a prediabetes subgroup, 10-hour time-restricted eating lowered nighttime average sensor glucose by about 0.3 millimoles per liter at 6 weeks. But fasting glucose and HbA1c were not different between groups, and the nighttime effect was not maintained at 3 months. That is interesting, not decisive.
If someone has prediabetes, obesity, or diabetes risk, fasting may sound low-tech and harmless. But if their sleep schedule is chaotic, they work nights, train hard, or use glucose-lowering medication, should the eating window be treated like a medical variable rather than a lifestyle challenge?
Yes, and when we move to 5:2, the evidence again looks more like feasibility than magic. In a small pilot after metabolic bariatric surgery with recurrent weight gain, 5:2 fasting was non-inferior to continuous restriction over 12 weeks. The fasting group lost about 1 kilogram and had higher adherence, but the study had only 20 participants. A behavioral trial also helps explain why fasting can feel easier for some people. Adults with obesity were assigned to intermittent fasting plus early time-restricted eating, calorie restriction, or standard care. Both active diets produced more weight loss than standard care at 2 and 6 months. But calorie restriction changed restraint and disinhibition more clearly, suggesting different psychological levers.
So the best candidate is not the person chasing autophagy slogans. Is it more like someone who naturally overeats at night, dislikes calorie tracking, has a stable schedule, and can still fit protein, fiber, vegetables, fruit, and other nutrient-dense foods into a predictable window?
Yes, but protect lean mass and total intake, especially in older adults, frail people, and heavy exercisers. In postmenopausal women, Nordic walking plus time-restricted eating looked better when high protein was included. The package without high protein had less favorable lean mass changes. That is not isolated proof of protein timing, but it is a practical caution against compressing food too aggressively. Judge fasting like a tool, not a doctrine. After 8 to 12 weeks, ask whether weight, waist, glucose, blood pressure, sleep, training, hunger, and food quality are improving without binge-restrict cycles. If not, change the window, use ordinary calorie guidance, or focus on diet quality. The evidence supports flexibility and preference, not fasting exceptionalism.